Hello. I'm going to talk to you today about gastric neuroendocrine tumours, and I'd like to thank Neuroendocrine Cancer UK for the invitation to speak to you on this topic. So because I'm not there in person, I thought I should tell you a little bit about myself to start with. So I'm Mark Pritchard. I'm Professor of Gastroenterology at the University of Liverpool. I'm a consultant gastroenterologist at Liverpool University Hospital's NHS Foundation Trust. In Liverpool, we host an ENET Centre of Excellence for managing patients who have neuroendocrine tumours. This covers Cheshire and Merseyside, North Wales, and the Isle of Man, and I'm currently head of that centre in Liverpool. So the topic of this talk is gastric or stomach neuroendocrine tumours. So just to remind you about the anatomy of the gastrointestinal tract. So when you swallow food, it passes down the esophagus into an organ called the stomach. And that's what we're going to focus on today. The food then passes on through the small intestine into the colon and is expelled from the other end. So the stomach is the fourth commonest site for neuroendocrine tumours within the GI tract after small bowel, rectum and pancreas. And that's going to be the focus of today's talk. So in order to explain how gastric neuroendocrine tumours develop, I first need to explain a little bit about gastric physiology. So one of the main functions of the stomach is to produce acid. And this acid is one of the things that starts to digest the food that you've eaten. So after you've eaten a meal in a normal healthy individual, cells in the stomach called G cells produce a hormone called gastrin. And this is important in the development of most gastric neuroendocrine tumours. The gastrin then stimulates an intermediate cell called the ECL cell to produce another substance called histamine, which then stimulates the parietal cells to produce acid. Now remember those ECL cells as well, because it's them that develop into neuroendocrine tumours in the stomach. So this is what happens in health. And we will explain how this is altered during the development of certainly types 1 and 2 gastric neuroendocrine tumours. So how do people who have gastric neuroendocrine tumours present? When I see somebody with a gastric net in clinic, how have they come to be at that point? Well, most tumours are actually found incidentally. They're found when a patient is having an endoscopy to investigate another issue. This is usually anemia, either an iron deficiency anemia or pernicious anemia, but it can be for a range of other causes. A few patients do have symptoms, and they are mostly symptoms that come from the stomach, things like indigestion or nausea or vomiting. But that's comparatively rare, and most people either present with anemia or no symptoms at all. So when I'm seeing a patient with a gastric net in clinic, what are the things that we need to do in order to find out about that tumour and work out what treatment is needed? Well, as with all neuroendocrine tumours, we need to know things like grade and stage. I'm sure these will be covered in other talks today, but just to remind you, grade is basically how fast the tumour cells are dividing and therefore how fast the tumour is growing. And stage is how far the tumour has spread from where it started, in our case, the stomach, to other parts of the body, such as the liver. So we need to know grade and stage as for other tumours. However, for gastric nets, there are also a number of specific things that we need to know. In particular, we need to establish the type of gastric net. There are 3 types, 1, 2, and 3, and I'll explain what they are as we go through this talk. It's also crucial to know how big the tumours are in the stomach and how many there are, because this will influence what treatment we can offer. And because lots of gastric nets are associated with underlying conditions, it's important not to forget about them, and other aspects of those conditions may also need treating, and I'll explain more about that as we go along too. So this is one of the take-home messages from my talk today, and if you don't remember anything else, I think this is an important point. And this is that in addition to standard things that we do for any NET patient, we also need to work out the type of gastric net. And you can only advise on the most appropriate treatment for a gastric net once its type has been determined. So there are 3 types of gastric net, 1, 2, and 3. Type 1 is the commonest. It accounts for about 80% of cases. And in this type, the tumours arise in patients who've got pernicious anemia or atrophic gastritis. That's a stomach that doesn't produce adequate amounts of acid. Type 2 gastric neuroendocrine tumours are comparatively rare. They only account for about 5% of the total. And these are associated with a syndrome called Zollinger-Ellison syndrome and multiple endocrine neoplasia type 1. Type 3 gastric nets account for about 15%. These are sporadic. These are not associated with any other known underlying condition, and arguably these are the most serious type of gastric net. This slide shows some more details about these types of gastric net, and this slide is a bit busy, but we'll go through it systematically. So in the first column, we talk about type 1 gastric neuroendocrine tumours. As I've said, these are associated with atrophic gastritis and pernicious anemia. Usually patients have multiple small polyps. The level of gastrin in the blood is very high, and the stomach produces low amounts of acid. Thankfully, the outlook for patients who have this type of gastric neuroendocrine tumour, which you remember is the commonest, is very good indeed. Type 2 gastric neuroendocrine tumours in the next column account for about 5%. Again, they're usually multiple small polyps in the stomach. And again, the gastrin level in the blood can be high. However, in this case, the stomach produces high amounts of acid rather than low, but the outlook is still good in most patients. Type 3 gastric neuroendocrine tumours, the sporadic ones, usually have a different appearance. They're usually single tumours and often larger, more than 2 centimetres when they present. In these patients, the gastrin level in the blood is usually normal, and the stomach normally produces normal amounts of acid. The outlook in this type of tumour is poorer, particularly if untreated. However, if the tumour is detected at a relatively early stage and removed by an operation or through the endoscope, the outlook is still good. So in view of this, a number of tests are needed in patients who have gastric neuroendocrine tumours in order to work out what's going on and what treatment is necessary. One of the crucial tests in this type of tumour is a gastroscopy, and I'll talk more about that in the next slide. Patients also need a set of blood tests, in particularly measuring the level of gastrin in the blood, but also other things such as the level of vitamin B12. For the gastrin blood tests, it's important to fast overnight, so not eat or drink anything for about 12 hours, as food affects normal gastrin levels. This blood test usually needs to be done in hospital too, rather than at a GP surgery, because the blood has to be processed in a special way before it's sent to the lab for analysis. Patients with NETs sometimes also need the usual sorts of staging tests that most NET patients have, things like CT scans, octreotide scans, gallium scans. But sometimes they also need something called an endoscopic ultrasound scan, which is like an endoscopy, but it has a scanner on the end of the camera rather than just a camera itself. So I'm sure lots of people who are listening to this talk will have had an endoscopy, or some of you may be facing an endoscopy. In the UK, endoscopy is usually either performed with some sedation to make you drowsy, or with a local anaesthetics throat spray to numb the back of the throat. In other countries through the world, endoscopy is often performed under a general anaesthetic, but that's not normal practice in the UK. It normally takes about 10 to 15 minutes to do, and most people tolerate it pretty well. Some people, especially if you have a pronounced gag reflex, can feel it uncomfortable, but most people manage to get through it. The image on the left at the bottom shows the appearance of the normal stomach through an endoscope. And I'd like to point out the folds in the stomach and the sort of rough appearance of it. And just bear that in mind when we compare it with some images that I'll show in later slides of various neuroendocrine tumours. So gastroscopy is usually a very safe procedure. There are some risks, it's very low when we're just having a look and taking biopsies, but these are a little higher if we're operating in the stomach and removing tumours through the endoscope. So let's move on now to discuss the three types of gastric neuroendocrine tumour in turn. So this is how type 1 gastric neuroendocrine tumours develop. Unfortunately, I can't use a pointer to take you through this slide because of the filming, so I'll try and explain it in a little more detail. So in type 1 gastric neuroendocrine tumours, what happens is that your parietal cells are destroyed by an autoimmune process. That's the big X on the right. So as a result of the parietal cells being destroyed, the stomach doesn't produce acid. And it also doesn't produce intrinsic factor, which also comes from parietal cells. And that's what leads to this condition called pernicious anemia, or vitamin B12 deficient anemia. As a result of the stomach not being able to produce enough acid, the G cells produce more and more gastrin in order to try and stimulate the stomach to produce acid, but it's not able to do so. So it makes more and more and more gastrin. This gastrin then acts on the intermediate cell, which is called the ECL cell, remember, and that increases in number, and this can lead to the formation of type 1 gastric nets. And because this is happening throughout the stomach, often these tumours are multiple. These are some examples of a gastric net, a type 1 gastric net. You can see multiple polyps in the stomach of this patient, these sort of raised areas, but the background mucosa, the background lining of the stomach, is smooth. That's what's known as atrophic gastritis. In the right-hand image, you can see the biopsy forceps coming through the channel of the endoscope in order to take a biopsy. This also allows us to measure the polyps because the opening at the bottom of the forceps is about 6 or 7 millimeters in diameter. So the good news for most patients who have type 1 gastric neuroendocrine tumours is that the outlook is excellent and that they don't need any treatment whatsoever. So for polyps that measure less than 1 or 1.5 centimetres in diameter, particularly when they're grade 1, no treatment is usually needed, and we simply offer regular endoscopic surveillance to make sure that the tumours are not growing or changing, and most of them don't. Some of the larger polyps, or if they're slightly higher grade, we advise resection, and in most cases we can do that through the endoscope. In a few cases, particularly if it's not removable through the endoscope, the patient may need surgery to remove it. There are a few reports of using somatostatin analogues in this condition, but it's not normal practice. And later on in the talk, I'll describe some work that we've been conducting in Liverpool, a trial of a new tablet treatment for this called a gastrin receptor antagonist. Many of the patients with type 1 gastric nets also have vitamin B12 deficiency, as I've explained, and that will need regular vitamin B12 injections to treat the anemia. So moving on now to type 2 gastric neuroendocrine tumours. These also involve gastrin, but in a somewhat different way. In this condition, what you have is a gastrin-secreting tumour called a gastrinoma. This isn't usually located in the stomach, but further down the GI tract in the duodenum, or alternatively in the pancreas. So this gastrinoma produces high levels of gastrin, which then stimulates the ECL cells to grow again. And these are what can develop into type 2 gastric neuroendocrine tumours. But in this condition, the histamine that's produced by the ECL cells can still act on the parietal cells, which again increase in number and lead to the production of more and more acid. This acid production has other consequences. It can lead to the development of ulcers in the stomach, the duodenum, or even further down the small intestine. And this is a syndrome called Zollinger-Ellison syndrome. Type 2 gastric neuroendocrine tumours, as I've mentioned, are quite rare, and even though I specialise in this field, I've only seen a few cases throughout my career. This is an example of a patient who I saw many years ago who did have some very small type 2 gastric neuroendocrine tumours. He had a CT scan, which showed a gastrinoma located in the duodenum, and this was also shown on the octreotide scan on the right. So what's the treatment of type 2 gastric neuroendocrine tumours? Well, the first thing you need to do is to put the patient on high doses of proton pump inhibitors. These are drugs like omeprazole that you will probably be familiar with, and they will lead to the stomach producing less acid. This treats the ulcers but doesn't do anything for the underlying neuroendocrine tumours. But it is important to have healed ulcers before embarking on any other treatment. If you can then find the gastrinoma, which is not always possible, the main treatment would then be to remove it surgically. That may involve major surgery, such as a Whipple procedure. In some patients, particularly if the gastric neuroendocrine tumours are larger or causing a problem, they may also need to be removed. And this can sometimes be done through endoscopy, occasionally requires surgery. If the gastrinoma has metastasized or spread at the time of diagnosis, sometimes we also use somatostatin analogues in this condition. It's also important not just to focus on the gastrinoma and type 2 gastric net here, but remember that the patient is likely to have multiple endocrine neoplasia MEN1, and not forget to assess and treat tumors in the parathyroid gland or pituitary gland. And because this is a genetically inherited condition, you also need to screen other family members and involve a geneticist. Moving finally on to type 3 gastric neuroendocrine tumours. Well, these are what are called sporadic tumours, which means that we don't really fully understand how they develop. However, we do know that they're not associated with any other underlying cause. And in this type of gastric neuroendocrine tumour, the gastrin level in the stomach and in the blood and the acid production in the stomach are all normal. So these tumours can look somewhat different, as I've shown in this image here. These are usually single polyps and they can be larger. This is a patient who I saw recently who's got a relatively small tumour measuring nearly a centimetre or so in size. You can note here that the folds in the stomach can still be seen, unlike in the patient who had atrophic gastritis. And that's suggestive of normal acid production in this patient's stomach. So what's the treatment of gastric neuroendocrine tumours type 3? Well, if the tumour hasn't metastasized, and the patient will need some scans to confirm that, the main treatment is to remove it. Most patients need surgery, and that's certainly been the recommended treatment historically. Nowadays, if you have a small tumour and low grade, it may be possible to remove it through the endoscope and avoid major surgery. Unfortunately, some of the patients who have type 3 gastric nets, the tumour will have metastasized by the time it is found. And in that case, we use the same sort of treatment that we will use for other metastatic nets. So for low-grade tumours, grade 1 or 2, we will use somatostatin analogues, followed by things like PRRT if it progresses. Whereas for grade 3 tumours, the more rapidly proliferating ones, chemotherapy can sometimes be useful. So I'd finally like to end by describing a little bit of work that we've been doing in Liverpool over the last few years into new treatments for gastric neuroendocrine tumours. Some of this work has been funded by 2 research grants that we've won from Neuroendocrine Cancer UK. So I thought it would be interesting to explain to you how this money has been used and what we have achieved so far with your generous donations. So a few years ago in Liverpool, we conducted a trial of a potential new treatment for gastric neuroendocrine tumours. This is a drug called nitazapide, which is taken orally once a day. The drug is produced by Trio Medicines Limited in London, and it's still in development. So this isn't a medication that can currently be prescribed to patients, and the company still needs to be doing more trials before it can be approved for use. In this first trial, we recruited 8 patients in Liverpool and 8 patients in Norway, all of whom had type 1 gastric neuroendocrine tumours. We initially gave them the tablet once a day for 12 weeks, and when it was well tolerated in that study, we gave it to most of the same patients for a following 12 months. This is an example of the response we saw. This is only at 12 weeks. We've got two patients here. Top two images are patient 1, bottom 2 are patient 2. Left images are at the start of the trial, and the right images are after 12 weeks. And you can see polyps in these patients which got smaller after 12 weeks. Again, unfortunately, I can't point at these with a pointer, but I think you can appreciate the lumps in the stomach, the polyps, which are smaller in the right-hand images than the left. When we carried on the trial for 12 months, 52 weeks, we then analyzed all the information. This slide is very busy, but essentially what it shows is that we had a small reduction in the number of polyps. Remember, most of these patients have multiple polyps, at least 10 or so. However, the most interesting effect we saw was a decrease in the size of the largest tumor. So in a few patients, they went away, but in most, they reduced significantly in size. We also saw a reduction in the chromogranin A level in the blood, which many of you will be familiar with as a biomarker of neuroendocrine tumors. The gastrin level in the blood didn't change, but that wasn't expected. So that was, again, a confirmed response. So we published the results of this trial a few years ago, and we've been using the samples from the trial to make further analyses. And one of the things that we've recently found with Neuroendocrine Cancer UK funding is a new potential biomarker of the response. This is something called PAPA2, which is not something that has previously been associated with gastric neuroendocrine tumours, but we found that the amounts of this PAPA2 were related to the treatment. So when we had the patients on treatment, the amounts of it went down. When we stopped the treatment, it came back again. So that's a promising new biomarker that we've discovered in Liverpool recently. And what we're doing with the current funding that we have is to try and develop a system whereby we can test the effects of potential new drugs in the lab before we ever have to give them to patients. And in order to do this, we're exploiting a new technology called gastroids. So what we do here is we take samples from the patient's stomach, biopsy with their consent, and we can grow them in a Petri dish in the lab, as illustrated on the left-hand panel here. And these gastroids form little spheres, which we can grow in tissue culture, and then we can treat those in the tissue culture dish with gastrin or with potential new drugs to see how they respond. So we did that with gastrin and with nitazapide in some research that we've recently published in the journal Cellular and Molecular Gastroenterology and Hepatology. In the right-hand image, we show that when we treated these gastroids with gastrin, they increased in size. When we co-treated them with gastrin and nitazapide, though, that response wasn't seen. So the nitazapide blocked the effects of gastrin in these gastroids, which is essentially what we saw in the patients. We also saw the same response on our biomarker PAPA2. So gastrin increased the levels of PAPA2, and that was inhibited by treatment with nitazapide. So this is a promising new, what we call in vitro system, a tissue culture system in a dish that will potentially allow us to test a range of potential treatments before we ever have to embark on clinical trials to see whether they are promising or not. There's still a lot of work to do, and our research obviously has been slowed down by the COVID-19 situation, but we still have 12 months of funding in order to pursue this project. So I'll draw things to a conclusion in this final slide. As I've already mentioned, one of the main take-home messages of this talk is that establishing the type of gastric net is very important, and this is essential before you can embark on treatment. I would therefore suggest that in most cases, the assessment, follow-up and treatment of gastric neuroendocrine tumours is best undertaken by a gastroenterologist who's interested in nets and who is able also to conduct the endoscopies that are required. However, fortunately, the commonest type of gastric net, the type 1 gastric net, has a very, very good prognosis. Many patients don't need any treatment, and in the majority of cases, this has no effect on either patient quality of life or length of life. And finally, I'd like to thank Neuroendocrine Cancer UK once again, both for the invitation to speak to you today, but also for funding the research that I've shared the results with you in the last few slides. So thank you very much and goodbye.